So, hello and namaste to all of you. This is J.K. Singh from Department of Physiotherapy and Diagnosis. So, in previous lectures, we were discussing about vitamin D and absorption of calcium. So, basically, calcitriol it promotes the absorption of calcium and phosphorus from the intestine. And on the brush border surface, calcium is absorbed passively. And from intestinal cells to blood, absorption of calcium needs energy. So it is either by sodium calcium exchange mechanism or by pumping out the calcium cal binding complex. Now, calcitriol it acts like a steroid hormone, and on entering the cell, it binds to specific nuclear receptor VDR, which binds to VDRE on the elements upon forming a dimer with RXR. So the transcription activation of specific genes that code for cal binding it occurs. So due to increased availability of calcium binding protein, the absorption of calcium is increased. Now, what is its effect on bone? So mineralization of bone is increased by increasing the activity of osteoblasts. Now, calcitriol it coordinates the remodeling of bone and increases the bone mineral density. Now, active vitamin D has action on all three types of cells: osteoblasts, osteoclasts, and osteocytes. So, the intracellular conversion of 25-hydroxy D3 to calcitriol by osteoblasts promotes their differentiation and mineralization and osteoclastogenesis. So, from multinucleated precursors induced by osteoblast secretion of receptor activation nuclear factor kappa B ligand, and which is a cytokine. So osteoclastic bone resorption and alkaline phosphatase activity of osteoblast, it will provide adequate calcium and phosphorus to promote mineralization, and the hypercalcemia induced secretion of fibroblast growth and factor 23 from osteocytes, which upregulates 25-hydroxylase. This completes the negative feedback loop on PTH secretion. So the hormone is responsible for increased production of bone matrix proteins such as collagen, osteocalcine, and osteopontin. So what is the effect of vitamin D on renal tubules? So calcitriol it increases the resorption of calcium and phosphorus by renal tubules, and therefore both the minerals are conserved. So PTH, it conserves only calcium. Now regulation of calcitriol by the formation by feedback control. The hormonal level of calcitriol is maintained by the feedback control. So the rate of production is modulated by serum levels of calcium, phosphorus, PTH, and calcitriol itself. Now, the major site of control is on the 1-alpha hydroxylase of kidney, hypercalcemia, which decreases calcitriol, low dietary calcium, hypocalcemia, increases the rate of 125 DHCC. The stimulatory effect of hypocalcemia on 1-alpha hydroxylase is through PTH. So hypercalcemia decreases calcitriol, and the half-life of 125 DHCC is 6 to 8 hours and is mainly excreted through the bile. So inactivation is by oxidation of the side chain. So hydroxylation at 24th position by kidney also lowers the activity. And in vitamin D deficient state, that is low calcium and phosphate, it will enhance the action of 1-alpha hydroxylase. So when vitamin D status is adequate or calcium level is high, 25 hydroxylation is favored, forming 24-25 DHCC, which is less active, and 125 DHCC levels, which is directly regulates PTH secretion. Now, deficiency of vitamin D. So the deficiency will decrease of deficiency diseases are rickets in children and osteomalacia in your adults. So vitamin D is also known as anti-rectic vitamin. The optimal concentration of 25-hydroxy D3 is more than 30 nanograms per ml. and whereas 20 to 29 nanograms per ml is considered insufficient, and 10 to 19 nanogram per ml is deficient. So a level below 10 nanogram per ml indicates severe deficiency. So the concentrations more than 150 nanogram per ml is toxic. So current moves to decrease vitamin D is in blood are RIA, CLIA, HPLC, LC, and tandem mass spectrometry. So it is well known that advance in age and presence of melanin will decrease the formation of vitamin D3 on skin. And various studies have shown that 15 to 80% and 20 to 50% of children have hypervitaminosis D. And even in affluent countries, vitamin D deficiency is very common. So deficiency is more common in obese people because vitamin D is stored in adipose tissues and is not released for a utilization. And vitamin D deficiency was associated with poor health, poor bone health, low calcium concentration, high systolic blood pressure, and lower HDL cholesterol value. So all of which are risk factors for heart diseases. Now the role of vitamin D on prevention of cancer is it provides a very important therapeutic use for the vitamin. So children, adolescents with vitamin D deficiency are at higher risk for allergies and asthma. So what are the causes of vitamin D deficiency? So deficiency of vitamin D can occur in people who are not exposed to sunlight properly, or inhabitants of northern latitudes in winter months, in people who are bedridden for long period, and those who cover the whole body, such as in case of Parda. So nutritional deficiency of calcium or phosphate may also produce similar clinical picture. So malabsorption of vitamins in case of obstructive jaundice and steatorrhea, and high phytate content in diet may also reduce the absorption of vitamins. So abnormality of vitamin D activation, liver and renal disease may retard the hydroxylation reactions. So the deficient renal absorption of phosphates. Hypervitaminosis D has emerged as a lifestyle disease by the beginning of new century, and about 1 billion people all over the world are about found to have deficiency of vitamin, which was being considered as a thing of the past. So the lifestyle changes that now keep people indoors, both adult and children, and widespread of sunscreen are responsible for this change. So further about the disorders of vitamin D deficiency, that is rickets and osteomalacia, we'll see in further lectures. And until then, if you have any doubts regarding these topics, you can contact me. Until then, take care and